to mention this can run about 60 minutes or an hour and a half if that's if you have time, and that's kind of a luxury. However, that we do, I'm sorry.
Karen, I'm so sorry for interrupting. Are those times somewhere? Like, are the times like, are we like, or are those times somewhere? Like, so we know that when we start looking through the different ones, or we just like, how do you predict that it's going to be that long or not? And do you have it somewhere notated, or we just have to know that?
It's and it, you know why I say it's short and it's long. Everybody presents at a different pace and they have a different speaking style. So these are just best guesses. And I think by practicing at home or giving it to someone else or recording it yourself and timing yourself, that's absolutely the best way to do it. And as we talked about last week, if you're running long, you can always take slides out too if you want to edit. Can't put new slides in, but definitely if there are some slides that you think are not essential, or you've been given a 15-minute time limit and you know this deck is long. I mean, it's 47 slides. You just want to pick out the top 15 slides, you know, that could help, but it's not a science. I wish it was. It's all very individual. So the second slide is where you customize it. The third is a nod to the Care Partner Project. The next slide is always the agenda because people like to know what's coming up. And most importantly about this is that you are going to allow them the time. You're going to allow the time for questions and answers afterwards. And I encourage you to let people know that you'd like to get through the presentation and then save all questions till the very end. Also, you can mention here that don't worry about taking notes because I'm going to send you a handout which will have all of the notes, and therefore for you as a presenter, it's much easier to engage with your audience, you know, to just set up a rapport if people are not having to take notes. So then this launches into the presentation itself. And you will see that we have some slides in there that I kind of think of as filler or transition slides. You know, in the interest of keeping things shorter, you may elect to just do away with these transition slides. It's completely up to you. So the opening to this particular presentation is about a woman, Sarah, who went to the hospital for what her doctor called routine surgery. She had torn her rotator cuff because she was involved in all kinds of sports, and she thought it was just going to be an outpatient procedure. And as the story goes on, and one thing after the other happens, all hiccups in her care, all of them that happened despite the best intentions of her nurses and doctors. But in the end, she ends up 10 days later and she's in the ICU fighting for her life because she picked up a hospital-acquired infection. Okay. And as you read the story, you think, oh my gosh, I can see this happening. I mean, anybody who hasn't even been through healthcare or even been through a hospital care, it's so clear that everybody was doing their jobs. So at the end of the story, it says, now let's take another look at this. Sarah decided to bring her care partner with her, who happened to be her son. And she said, you know, I have this surgery tomorrow. Would you mind going with me? And would you go to the Care Partner Project and download the checklist? Well, in one of the checklists, he sees about how to prevent a hospital-acquired infection. And guess what? He followed that checklist. And guess what? She never picked up an infection. And guess what? She was discharged without a problem, without any complications, just because of the simple steps that her son was able to take as her care partner. So this story has received a lot of great feedback. You may have stories of your own, though, from your own experience, that if you would rather substitute a story, and it doesn't even have to be as dramatic as this, but in some way that will show how being informed can actually help support safe care without complications from your own experience as advocates or even personally, please, by all means, go ahead. And if you have an opportunity to say, and guess what, I got all this information, or all this information is available at the Care Partner Project, that's all to the good as well. So this first section, it kind of goes into, well, what are the concerns that we have about, why are we even talking about getting safe and sound care in the hospital? Where are the potential cracks in care? And I should mention to you that we never use the word medical error. We never use the word medical mistake. And in part because those words carry a lot of baggage. And as we all know, the blame game falls upon the individual providers, the nurses and doctors. And as we all know, it's not the nurses and doctors so much as it is the system that puts them in places in untenable positions, oftentimes, to be able to, they just don't have the time to sweat the details for great communication and the small details that actually add up to safe care. So we're very positive. We, among us, we may roll our eyes. We may get really frustrated with healthcare, but we never betray that to the people that we're talking about. It's all about the positivity of how we can work together, and we all pitch in for patients. We just have to know where the concerns are and what we can do. So we get into why. Why do these things happen? They are called never events, by the way. This is not a term that we just made up. It's in the script. It's a term that was actually coined by Medicare, because they're entirely preventable and they should never happen to any patient, but they do, upwards of 13 million times a year. And upwards of 400,000 patients a year die from one of these preventable events. And that's all in your script. So why? Healthcare is complicated. We have people who are doing their level best professionally, but guess what? They're under a lot of stress and they're strained. And then something that's completely normal is that patients forget up to 80% of what they hear. And so as we say, that is normal. You're under stress. That's why you need a care partner with you, the second pair of ears and eyes to help you remember what is so important, the information that you pick up in the hospital, but can be so easily forgotten. A study at Yale revealed a few years ago that 3 out of 4 patients age 65 plus leave the hospital with an incorrect prescription or no understanding of their medication schedule to follow at home. Now, there's lots of money for studying the Medicare population. That's why it was age 65 plus. It doesn't mean that people who are under the age of 65 don't also have the same concerns when they're leaving the hospital. It's just a lot's going on at discharge. The discharge papers show the medications typically like in single space, Times New Roman, it's not called out usually as apart from the regular discharge information. And it can be very confusing and hard to remember. And then there are too many round trips. 20% of patients end up back in the hospital within 30 days. And something like, I can't remember exactly what the data says, but a big chunk of those people who are back in the hospital is because of medication mix-ups, or they can't get their medications, or they can't afford their medications, or they take them improperly. Oh, I'm supposed to take it 4 times a day. I thought it was 2 times a day. So it's all of those things that can be very fuzzy, again, related to medications can be very complicated. So now that we've given people all this bad news, and you can skip that if you wish, it's entirely up to you. We're getting into the solutions and tips. And I love this slide is because we have all been thinking for many, many years that patients are sort of passive. We take in what our physicians and nurses and providers tell us to do, but that thinking is over. We need to be collaborative. We need to be proactive. We need to be informed in order to support the best possible care. It is teamwork. So that's the new thinking, is that we're no longer passive patients, we're proactive patients. And here's a really cute video. I love this. And you may or may not have time for it. And it's really good to check your internet connection before. So if you have a chance to go to the facility or wherever you're speaking and just test this. And trust me, there have been many times when the internet connection has failed. So, so you might want to take this slide out if it's going to cause you problems. But this is a 15-year-old Morgan Gleason who represents the new thinking. And when you have a chance to watch this, I strongly recommend it. It's just so much common sense out of the mouths of babes, literally, and it's kind of hilarious. And I mean, it's funny, not funny, but it is the new thinking. We have to take our lead from good old Morgan at age 15. So here's another place where we insert that if you go to, if you need hospital care, you can go to the Care Partner Project and download all of their simple little quick checklists that tell you what to look for, what to say, what to do, and importantly, when to get a nurse, because they can't be everywhere. And you can be those extra pair of eyes and ears. We also really are crazy about and support every which way we can that this whole idea that, yes, okay, you love your doctor, but where is your doctor affiliated? Are they affiliated with a hospital that's highly rated, an A hospital, a B, a C, or a D, or an F? I mean, there are F hospitals out there, and you can find out. And then you have the opportunity to understand, too, by their ratings, where they are falling down on the job. There are many times that you may have a doctor who is tops that you need to see for whatever condition is being treated, but they're only in a so-so hospital. And it's not to say that you have to go find a new doctor. It's just, you may definitely have your care partners fully on board to be there with you. I recently had to look up for a friend a hospital. He was in the emergency room in a hospital in Florida, and they wanted to admit him. And I quickly looked up the rating of that hospital. And it was a case where it was a fabulous surgeon, #1 surgeon, but that hospital was a C. And I had looked over the last history, and they've been a C for years, which really said to me is they're not interested in quality improvement. If any of us were heading up a hospital that was a C, would we let that stand? No, we wouldn't. We would be an A, and we would be an A so fast. And the hospital, the fact that they were complacent. So he did check himself out. It was not an emergency, and he found another surgeon. And what we did is we looked for an A hospital in his area. And so now we have a good package of an A top doctor and an A hospital. So that's very useful information. We also clue people into the fact that for every diagnosis or surgery recommendation, get an independent second opinion. That means that you don't go to the doctor's friend. It's extra work, but it is important that they are truly not in the same practice, because we all know that doctors are loath to second guess their colleagues. And while, maybe this isn't 100% universally true, it is enough of a trend in order to be cautious and just exercise caution. So at the Care Partner Project, we have a checklist of questions to ask for all of your doctors when you're trying to figure out whether that surgery recommendation is truly right for you. And then, of course, if it is, all the questions to ask to make sure you're totally well prepared for that experience. And so they can go to the Care Partner Project and download those checklists too. Some of the highlights are when you're interviewing surgeons are ask, how many of these have you done? The 30 is not good enough. 300's okay, but you want somebody who's done 3,000, right? You want them to be able to do this in their sleep and to have seen absolutely everything. Recently, a friend of mine had a patella surgery. Her kneecap cracked in half when she took a big fall. And she had a surgery and it failed. It didn't work. When the doctor opened it up, fully expecting to see some healing going on, it was still cracked in half. And his reaction was, whoo, I've never seen this before. And then she promptly rescheduled the surgery with the same surgeon. He had never seen it before. His first initial surgery had failed. And she still, like, I have to tell you, I was on pins and needles until she got through that second surgery. It actually worked. And to his credit, he explained to her how he had failed and what he was going to do to correct the situation. But that's not really what you want to hear is, whew, I've never seen this before. So if you have stories like that to share, please do. Another tip here is introduce yourselves. Studies have shown that doctors and anybody who's in the operating room, if they take the time to actually introduce themselves, that the outcomes are better. A lot of people really don't understand or don't know is that oftentimes surgery teams come together and they're pulled, you know, the nurse may have never met the doctor and this anesthesiologist may never have worked at that doctor, and they're all strangers. Well, strangers do not collaborate as well as people who simply know who's who and have a first name familiarity. And then another thing that's been coming up is asking the question, will you perform this surgery or yourself or with others? And in teaching hospitals is often with students. And if it is with students, it's the patient's right to know who are the students who will be there and what are the roles the students will be taking. And it's also patients' rights to be able to say, you know what, I'm not really comfortable with that. I really just want you to do it. Some people, I mean, obviously, some people will say, oh, okay, I get it. Everybody's got to learn. But just to be fully informed, that's part of what it means to have, to make an informed decision about these things. Another question that comes up, and this is happening more often, is to ask, hey, are you going to be doing another surgery at the same time you're doing mine? Because physicians are tag teaming. They're going from one surgical team to another down the hall, and they're going back and forth as needed. You know, it's not our place to say whether this is good, bad, or something else. Again, this just goes to how fully informed the person is when they're going into surgery and how comfortable they are with the process. Another question, which I don't think a lot of people would ask, is like, hey, are you planning to go on vacation or take days off? Or if you're having surgery on the heels of a holiday, which many people do because they have time off, they need to understand, is their surgeon, their doctor going to be available in case there are any complications? Or will they be handed off to a colleague who is doing backup for them? Again, we're not saying that backup person is not a good person. It's just to be fully informed and fully aware of who is your team and are they available to you is just part of that process of making a decision for any kind of surgery. So another obvious tip here is take good notes. Bring a notebook. Make sure that the people who are with you take notes, and then leave the notebook in the room, because your spouse may come for 4 hours and then your daughter may come for another 4 hours. But if for them to take the notes and then leave the notes so the next person can pick up, that's part of continuity of care. And that is a buzzword that stands for quality in any healthcare situation, is we're looking for continuity of care. And the family member or any care partners can be part of that. So some of the questions to ask to jot down in your notes is ask first thing in the morning with rounds if you can be there, if the care partner can be there, or if the patient can ask, what is the plan of care today? Plan of care, 3 little words that mean a lot to providers. It's the shorthand for, okay, this is what's going to happen today and why. And so they'll talk about the goals, the meds that are going to be started or stopped, the test results and the tests that are scheduled, and anything else that they may have on their minds. However, it is really important to share the patient's goals, because the patient's goals can influence what that plan of care is. I'll just give you a perfect example. In my dad's case, we asked him, Dad, what do you want today? This was when he was in the hospital after his transplant. And he said, and this kind of broke my heart, but I did share it with the doctors and we did have a good conversation. His goal was to have a chocolate milkshake. That's what he wanted. He loved his chocolate milkshakes, but to him, that meant he was on the road to recovery. He was resuming a normal life. It was a treat. He had been through a lot and he just wanted that chocolate shake. And the reason why that opened up a good conversation is because the doctor had been thinking about putting him on a feeding tube because his swallow reflexes were not good. And they were worried about liquids going into his new lung. So that was a really tough conversation, but I don't know if we would have had it unless I had shared Dad's goal about the milkshake. It sounds like a small thing, but it can make a difference. The patient's goals are really important, and their questions, of course, and their concerns. So, and this is something else that you keep in your notebook. People are filtering in, going in and out. Who are these people and what do they do? It's really important to understand because they also change from shift to shift, and just putting their names on the whiteboards, that does not necessarily explain what their role is and how that role may be important to the patient. Sweat detail every detail of every medicine. Good resources to look them up are Medline Plus, the Beers list for seniors, and the Kids list for kids, obviously. The last 2 are lists that have been compiled showing medications that are that to use with caution for seniors and with kids, because at different ages, medications are metabolized differently. And it's really, it doesn't mean for sure, it's not saying, oh, this doctor recommended this medicine for my child or my dad. It's good to have a conversation if one of those are prescribed. It's like, okay, what is the rationale here? Again, we're not encouraging people to second guess, but really to bring to the fore good information for good conversations.
Can I say something here, Karen?
Sure.
So one of the things that I always talk about with people in the medications, and you're talking about the book, nurses come in and they tell you what the medication is for. Oh, it's time to take your pain pill. Oh, this is your blood pressure medication. Ask them what the name and strength is and write it in the book.
Perfect.
Because this is where we get into, they're using a different drug in the same family as what you had at home, and this can create a mental conflict. So if they're on lisinopril at home, but the hospital formulary is an Enalapril, and they say, well, it's his blood pressure medication, Enalapril, and you're like, no, he's not on Enalapril, he's on lisinopril. But they don't, the care provider and the patient may not understand, we just had to change it due to what the hospital has. So always writing the name and strength down of whatever the type of pill it is can open up discussions, but can also keep things in that continuity of care.
Great point. Great point. Thank you so much. So here's the keep track of the meds. The nurses have the 5 rights of medication administration. So we're following right around along that. Is this the right patient? Meaning that's, and this is where you might want to explain. I know some patients, it just drives them crazy because their wristbands are checked and they're asked to say their name, and and the information is repeated multiple times a day. Some people think that that means that people have forgotten about them. It's just a safety check, especially for medications. So they confirm this is the right patient. This is the right drug, the right dose, the right time, and the right route. The route might, it means, is it by mouth? Is it intravenously? So just keeping, again, in your notebook, keeping track of those medications and, heeding Nancy's good advice here. Keep track of the tests and the test results. I hear a lot about, it's like, okay, they're taking blood or they're taking urine. Okay, what are they going to do with it? What is the information? Why am I giving up all of this blood? Ask at the time that these things, tests, fluids are being collected. What are the tests, and what are we going to learn, and how will that apply to my care? It is amazing the number of tests that are repeated over and over again. And I don't know about you, but this over testing and over treating, and a lot of people say, well, insurance covers it, it's no big deal. Well, yeah, it is a big deal because ultimately it's cost that we all bear, ultimately in our premiums. Another big point is in the hospital, you can really feel rocked back on your heels if you don't understand the terminology. You don't understand the vocabulary of healthcare, and that is very, very common. So, oh, I see. Okay, I'm sorry. On this slide, I got a little bit confused because I have another deck when I'm giving nursing conferences where I show them on one side what you say and what patients say. So I was thinking that slide was in this deck, but no, you are fully capable of running through, and this is a good audience interaction thing where you can say to yourself, okay, how many of you people know what a PCP is? Because that's often, or TPN or any of the medical terminology that might even be short little words, but are just not in anyone's everyday vocabulary. So on the spot within audience interaction, you can get this conversation going, or at least some back and forth. NPO is another one. And they'll write it on the whiteboards, but that doesn't mean anything. So about this Google University, everybody has heard that doctors say that they don't want you to walk in with all of your research. But guess what? This is the world we live in. And so if you could kindly suggest to people that they use, sort of a .gov sites or any universities or any, Mayo has a lot of good information. Help, especially during these times where disinformation is everywhere. Like, do not pick up information on X or Twitter or whatever. Please encourage them to trust science, to trust the people that are actually doing tons of research in controlled ways, disciplined ways. And then if they bring it in, try to do a little synopsis, like, take notes and have those notes lead to like questions or concerns. So it's a very concise way that they may want to cover this information with their physicians. And again, the other side of this, the flip side of this is that if the doctor is recommending some sort of surgery or procedure, you can go to Google. If you only have 10 minutes to go over it with them, look it up, see, okay, what is involved in this? I have a friend, actually a doctor, who had a brain tumor, and she asked me to help her because she felt like she had too much information being a physician. And so one of the things I found for her was actually a video of what that procedure would be going into her brain. and it was on Google, but it was at University of Michigan. And it actually ended up helping her get to the right doctor, but she really appreciated having that video. So there's all kinds of stuff you can find that's unreliable sites. Helping people to get friendly with a hospitalist is really kind of a big one, especially for older people, because it is really, really tough. In fact, a few years ago, we were getting a lot of comments on our website about what is this hospitalist. One person wrote to us and said, I'm going to sue Northwestern Hospital here in Chicago because I couldn't see my internist. I couldn't see my doctor. They would not let my doctor into the hospitalist. I had to work into the hospital. I had to work with a hospitalist. So it's just tough if you've got a long-term relationship. There is absolutely nothing we can do about it. That is unfortunate, but if you help people to understand that this is what's going to happen, it might be easier. And it's also good, I think, to give them a heads up that a hospitalist manages about 23 patients on average every shift, and hospitalists change during every shift. So this is reason number 405 why it's really important to have your care partner with you, because it's sweating these little details that maybe an internist would have done at some point, back in Marcus Welby days, doesn't anymore. That's where the care partner does step in, whether it's a friend, relative, or a professional advocate. Another big thing is the number one way to help prevent infection, which is the number one cause of unwanted complications in healthcare, is to wash hands and make sure everyone else does too. Even though it's really hard, and if you acknowledge, hey, yeah, it's easy to ask a 3-year-old to wash their hands. We know it's not so easy to ask a physician or a nurse or visitors, people coming to visit you, but it can be the matter between life and death. And you can learn how to wipe these out. Again, we have a checklist at the Care Partner Project. Another way to fight infection is stock up on your hand washing equipment, your supplies. I think it would be helpful to point out that in the hospital, all of the cleanup supplies are on the wall next to the door. And guess what? If you, as a patient, want to make your own hands clean, you're going to risk a fall if you get up and have to go to the door. So another way to ask people to wash their hands is if you have a supply of these on your tray table and you can just hand it. Say, hey, stop where you are. Here, wash your hands. Do any of you know Eileen Carina with Pulse in New York? She has a great way of getting people to wash their hands. She always goes with a handful of Twizzlers, those red sort of licorice things. And she'll always say, hey, you like a Twizzler? Wash your hands. Here's a Twizzler to wash your hands. So humor helps, so that would be helpful to introduce, I think, a little humor. Another thing that we hope people will do is bring their Clorox wipes to the hospital, or you can ask for them there. And the reason for that is that there are 2 forms of hospital infections. One is sort of the typical staph infection that responds to alcohol wipes. Alcohol kills MRSA. C. diff, on the other hand, the only thing that will kill C. diff, which is a terrible gut infection, which can cause really terrible diarrhea that it sounds obviously very uncomfortable, but it can cause dehydration and heart failure. So bleach is the only thing that will kill C. diff. And again, you can go to the Care Partner Project and download the checklist for preventing MRSA, preventing C. diff, and another deadly infection that can be picked up in the hospital is sepsis, which is a bloodstream infection. So all of those are handy Care Partner Project checklists. falls are more common than you can even possibly imagine. People fall in the hospital even if they ran 5 miles the day before they were admitted. And the reason for that is medications, being in an unfamiliar environment, having, being weak, still having anesthesia hangover. And it's an equal opportunity hazard. So there are ways to do that, is just to make sure that you've got non-skid socks, you've got a proper support. In this case, it was a 3-prong cane. And just remember always, and for the care partners to remember always, and the Care Partner Project, there is a checklist for how the care partners can pitch in and help prevent their loved one from falling. So another tip is that, yes, it's really important to safeguard sleep, but if alarms go off and they don't wake up anyone, make sure that somebody gets help. So you can bring earplugs and eye mask for your loved one to use. You can manage visitors so that they're only coming during short periods of time, so that, the patient or your loved one can get restorative sleep. But when an alarm goes off, make sure that you get help, because there's something called alarm fatigue, where, and we all have done this, that if you've got a bunch of kids playing ball in your yard and you've got something to do, you can tune out the noise. If you're a nurse on the floor and you've got to do some serious charting, you can tune out the noise, and you don't do it consciously. It's just your body's way of helping you focus on the task at hand. Well, it does happen that alarms do go off, they go unheeded, and it can help people. It can really hurt people. My former husband's best friend actually died because of alarm fatigue. He went in for hernia surgery, went into recovery. He was supposed to leave by 6 o'clock that night. His wife was told, hey, you don't need to hang around here while he's in recovery. If you have errands to do, go ahead. He's going to be here for a couple of hours. She left. His alarm, while he was in recovery, he had a bad reaction to anesthesia, vomited up the contents of his stomach, and choked. And the alarms must have been going off. It takes about 2 minutes for somebody to choke. He was pronounced brain dead. The alarms had been going off, but nobody attended, and he died. So alarms do, we all need, this is another case where we need to pitch in and get people to pay attention to the monitors. Again, pitching in over the weekends, because it is like a ghost town on the weekends. The senior staff, rightfully so, get to take time off. Everybody wants the weekends off. So you've got very skeleton staff who are not always the most senior. So it's really important for anybody who's in the hospital to have somebody there sweating all these details we've just covered over the weekends and at 24/7. If something else that's really important is if you sense that your loved one is going downhill, and we all know what going downhill means, right? You can sense if somebody is just in trouble, a loved one especially, by the look in their eyes, by a twitch, by a tone of voice, and nobody is responding to you, or they're brushing you off, or there's nobody around to talk to, or they have you're just not getting the attention. You have the right to call what is the hospital 911. And that is, you go to a landline, you dial O for operator on the landline, and you say, I'm calling a condition help and need a rapid response team. You give the room number and the patient's name. Studies have shown that, at first hospitals were really universally aghast. Like, what? We're going to have people, non-medical people, calling for our doctors and nurses to rush to their rooms? Yes. and it's worked. It has resulted in a lot of saves, and studies have shown that people don't do this gratuitously. They do it when they really know something is wrong and they're not being heard. So the condition help and rapid response teams have saved lives, many lives. So if somebody is experiencing a new or sudden onset or increase of mental confusion, I can't even tell you how many stories I've heard about patients who have said, oh yeah, it's just, they're older, they're confused, it happens, maybe you should think about assisted living, maybe memory care, or maybe, a nursing home. And their loved ones are saying, no, 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 no. They went into this hospital reading the New York Times 2 days ago. This is not my mom. She does not have dementia. She is not. There is something about this. We need to get to the root cause, because it could be staph infection, UTI, a medication side effect, an overdose, an accidental overdose of a narcotic, or drug interactions. And sometimes confusion results from simply too much time spent in the hospital. It's called hospital psychosis. It's that feeling of boxed in that can cause hospital delirium. So I really encourage people to speak up. And then take the time you need at discharge. So this is a time when a lot of people say, oh, I'll go get the car. And they leave it to the patient to participate in the discharge conversation. Well, guess what? More than ever, they need that second pair of eyes and ears, because in effect, care is being handed off. And this is sort of another, medical hospital buzzword. It's the handoff. The handoff is occurring from hospital to home, and that care partner needs to be the link. Again, it's all about continuity of care. Who is going to provide that crucial link to the care that that person will get at home, because nobody is 100% when they're discharged. Also, you can speak up and ask if you can record the discharge instructions first, and discharge instructions, and you can ask first. Some recoil at this. A lot of medical providers do not like to be recorded because they get their defenses up and say, oh, I could be, we have this litigious society, and, I don't want this to end up in some sort of court case. No, if you explain the benefit to them by saying, everything you're saying is important. We don't want to miss any details. We want to get it right. And we don't want to have to bother you later if we forget anything. It's in their benefit. We want to be also compliant, which is another. So remember, after discharge, check in with your loved one every day for at least a month, and watch and listen for signs and setbacks in recovery. And for that first sign, get help. You do not want to end up in the emergency room. Ask people. Don't raise your hands. Get in to see your doctors. And then it's okay to ask for help. And here are some great resources. And of course, a professional advocate like yourself. Finally, let's support our nurses. They juggle a lot for several patients at once. And then on the left-hand column is ideas for how to support the nurses. The final slide is, or next to last slide is, let's talk. And this is where you can open up for questions and conversation. And hopefully you'll get to this slide to remind people about the Care Partner Project and what we can offer to them. And then, of course, for you, this is where you present your headshot in this green box. Again, how to reach you, and a thank you, and a request. If this was helpful to you, I speak on other topics. So please, let's chat afterwards. Let me know about any groups. Now, you will have your evaluation form where it asks the same questions. So you will be in good shape to to get ideas from them of other places where you can okay, so we're kind of running out of time in the so you'll see here that there's Sarah's story if you choose to use it. Their handout is here. This is what you can email to them later. All the slides with all the content. So you're going to collect their emails in the sign-in sheet, the raffle tickets, the evaluation form. Is there one other tool in there? So hopefully before they ever leave, you will have 3 different ways to get their email addresses. So you can send them a thank you note along with all of these notes. And the reason why we're doing it this way is because the print handouts kind of get in the way. They're expensive to produce, and just getting that contact by email is a good start. Remember we were talking about last week, it takes 23 impressions to make an impression. So they walk out as fans, you send them an email with this information, more fan support, and then you go from there. Okay. I haven't even looked at the chat. Okay, so other good ideas. Okay. Kathy Bowers has anyone been successful in having the patient request daily copies of medical records, for example, the daily meds? I have seen daily med lists given to the patient from the hospital. Also, I'm pretty sure that I've read that the patient can request a daily rate of their charges, but might not always be successful. You have to be proactive to review the charges that might have been made by mistake. Good points. And she said, I just read at home, do not use your dish towel to wipe your hands, lots of bacteria on it. I use paper towels, never sponges to clean I agree. I'm a big environmental recycler and all that, but I never use sponges or towels either for that reason. Now, questions, comments?
Karen, I just had a quick question. Are there any FAQs that, if you have like a Q&A session at the end, where questions that are common for any of these slides, so we can be maybe a little prepared?
That's an interesting question. No, you know what? I've never collected that from presenters.
Mm-hmm.
A lot of what I shared with you is in the script.
Okay.
So I don't know if that helps or not. And you don't have to, like, maybe I've given you too much information. But it's okay. If you don't cover all of these points, nobody's going to know.
Okay.
You're still, even if it's like one little point per slide, it's still super valuable.
Okay.
Okay. So yeah. I've been doing this a long time. So
I can tell.
I have so many stories, but I understand what you're saying. Now I've kind of made you nervous that you're not going to be able to answer questions. And if you can't answer a question too, you just say, you know what? I'll get back to you on that.
Okay. That's always a good answer.
Yeah.
Thank you.
Yeah. Or throw it out to the audience. Does anybody else know? That's a great point. Let's talk about that.
Mm-hmm. Okay.
So, Michelle, you've raised your hand.
Yes, I think I really had this question for last week when you're getting ready to, approach an organization about doing this or whatever. I thought I heard someone say that you had a list of possible your presentations, like to say, hey, these are your options if you want to pick something or whatever. Did I make that up? Okay, where is it? I was trying to find it, and I'm sure it's here. I just didn't see where on the website that was, like a sheet that shows like all of them like in one place.
Here, let me go into the Okay. So
Sure,
it
I'm
is
gonna
on
be.
the main website. And it's
Oh, the
under,
main website.
yeah, so it's under, oh, here it is. Community programs,
Um,
right here. And so here's the drop down menu, but they're all on one page.
okay, so if I click there.
And so you can scroll down,
Okay.
and last week I said, feel free to plagiarize if you want to create your own e-flyer. You can also send this link.
Oh, okay. So then in essence, they would see these here too. Okay, gotcha.
Yeah.
Gotcha. Okay, gotcha. All right, thank you very much.
Of course, that was a great question. Other, I'm
So I'm
happy.
just, this is Patty. So
Hi, Patty.
I'm just going to ask a question. I know that, obviously it would be, 100% better to have somebody with the patient all the time in the hospital.
Yeah.
But we have so many solo patients these days. And, at the rate we charge per hour, it's kind of, I don't know, it seems kind of hard to tell patients that they have to have somebody with them 24/7.
It is hard. It's a reality. And one of the things that you might want to talk about is, is how to buddy up with a friend, where you have I guess I'm assuming that at least among the women that I know, but everybody's got a best girlfriend. And if you could just be there for each other, sort of make a deal, that might be helpful. And I have to say, one of the reasons I have a former husband is that he would never be there for me if I was in the hospital. So we all have to find those people, I'm sorry for the snarky comment.
It is, I see her point, but it is true. It's anybody who's alone in the hospital, I just fear for them. I do.
Yeah. And I was having lunch a couple weeks ago with a friend of mine who's on the faculty of Rush Nursing School. Rush is a big hospital here in Chicago, and she said, she said, it's gotten so much worse. She said, I just can't even tell you. It's just gotten so much worse in the last few years. Everybody needs somebody. Between nurses, leaving, travel nurses who are there for a short period of time. She said it's really a sort of like a clock watcher mentality. It's not so much of a calling as it used to be. So. I don't want to leave you on a downer note.
I want to say thank you very much. It was a great presentation. And thank you for
Yes, absolutely it was. Thank you.
Thank you. Well, thanks for joining in, and I hope this helps you get out there, feel more comfortable booking some. Oh, I should mention, so we do have a Medicare presentation. Are any of you like really into the insurance aspect of stuff?
Yes, I am. I am.
Okay, so for the last couple of years, Gail Bick and I have been doing this Medicare presentation at a local senior independent living facility. Gail and I live close to each other, and Independent Presbyterian Homes asked us if we would do this. And it's basically because I know the guy who runs it. And so for the last couple of years, it's been a really huge success because it answers so many questions. And Gail then books time afterwards with people to help them with their re-enrollment decisions. And so because that doesn't fall under the patient safety world, I can't offer it in our toolkit. However, if you would like that deck, for a modest donation of $50, we will give you that deck to take and brand as your own. Just run with it. It can't be a Care Partner Project presentation, but it is a very good Medicare, and we will update it with the latest, Medicare came out this month with changes, so it will be completely updated. And then how we handle it is the senior facility, Presbyterian Homes, they set aside a day where people come in for 30-minute slots and they bring all their stuff and all their questions, and Gail is going to help them with that. And she's charging, her hourly fee cut in half. And so she's just going to be there for a day. They pay by check, so there's no invoicing, there's no contract, there's none of the formality, but it's sort of a done in a day project, where people, from what I've been able to tell in the last couple of years, have had great peace of mind that they're getting help. So I want to throw that out there. And if you're interested in doing a Medicare, now is the time to book, is if you call these senior living communities to see if this is something that would be helpful to their residents.
I have a question about that, Karen, about her going over help. Is she an insurance agent?
Oh gosh, no. Gail is an advocate.
No, I know that. I'm just saying that I'm very cautious because I'm a go-to person here, and I gather articles and send them to whatever, pros and cons of Medicare Original versus Medicare Advantage, that whole thing. But very careful not to give any advice. Just maybe she's just hopefully pointing out exactly pro and con. Here's your options.
Oh yes.
And
yeah. In fact, in our deck, the first thing we say is we are not affiliated with any insurance. We're neutral. We're just here basically to outline, what your options are, your range of choices. And and then, so what happens? So I think with Gail, she'll ask them to bring their prescription record and how much their prescriptions cost. And then they can go through the various plans to figure out, it's like I say, it's like data driven, and they make the decisions. She just helps them make sure they know what to analyze. I guess that would be the right word.
Right. So you're getting paid by the Presbyterian Home to come in.
Well, yes, it's a donation to the Care Partner Project. That's where I get involved.
Right.
And then, because that's not my, I'm not in business as a patient advocate, but Gail is. She handles all of the follow-up appointments.
Excellent.
And as I said, it was just the guy who is the director of that facility is a former neighbor of mine, and he asked me about it. So.
And I just want to tell you, you recorded last week. That was an unbelievable value, 100+ session to go over the little tips to market ourselves, to do this, and it was just fantastic. So I'm just so pleased. Thank you. Really, I'm so grateful for this hour a week. or hour and 15 minutes.
Okay, so I've taken you, oh my God, I've taken you so overtime. Okay, I'm sorry. But I will I'm gonna re-record this because it was so messy at the beginning. Um, but um, but I'm gonna keep Darlene's portion. I'm just gonna re-record my portion. So look for that on the website. Okay, so
Okay.
Darlene, thank you so much for sharing your tips.
Oh,
Everybody-
you're very welcome. Very welcome.
Have a great weekend, everybody.
Okay, thanks, Karen. Have a
Thanks.
great
Okay.
week, everyone.
Thanks.
Bye.
Bye.